Mike Gibson, Paul Ridker coming to you live from ESC 2025. Paul, you're talking about SMuRF-Less, but inflamed. Talk to us about SMURFs and inflammation.
Sure, Mike, it's always a pleasure to join you for these ESC conversations. We're very excited about these new data that we're presenting. SMURFs, besides being the cute little blue figures that we all see on our children's television, SMURFs stand for Standard Modifiable Risk Factors: hypertension, hyperlipidemia, diabetes, smoking. SMURF-less are people who don't have any of those major risk factors. And there's been a whole series of publications, mostly in secondary prevention, saying that SMURF-less patients having myocardial infarction are more likely to die from the MI, less likely to get appropriate therapy, more likely to be women, and it's just a worse scenario in general. But in primary prevention, SMURF-less is having a little bit of a life because there's been two major studies out saying that the classical risk factors account for only about half of all incident major vascular events. So what's the other half all about? Well, you know me, Mike, we're interested in inflammation biology. So we created this new clinical syndrome, which we're calling SMURF-less but inflamed. So no major risk factor, but an elevated high sensitivity CRP. In any event, we went to one of our major cohorts. We've got 12,530 initially healthy American women who by definition have no major modifiable risk factors. They're quite young, they're very thin, the BMI is 24, GFR is normal, the LDL is 102, everything's normal. You would not see these people in any risk factor. And our guidelines, our 10-year risk scores completely would miss these people. And yet, those who had a high sensitivity CRP at baseline, single random blood draw, greater than 3, so using less than 1, 1 to 3, greater than 3, they had a 77% increased lifetime risk of having a major coronary artery event, a 39% lifetime increased risk of stroke, and a 52% increased risk of any major cardiovascular event. That's after adjustment for everything we could think of adjusting for in addition, including body mass index and GFR, which go along with the PREVENT score. But Mike, I got to tell you, the PREVENT score or the European SMART scores, they would completely miss these individuals because by definition, other than age, they have no major risk factor at all. So the
Paul,
concept here, yeah.
how often would you reclassify someone then? What's the reclassification index or something like
Well,
this?
that's the thing, Mike. It's almost a complete reclassification because every single one of these people, by definition, would be told you're not at cardiovascular risk. And yet clearly we're seeing about a third who are in this category of an HSCRP greater than 3. I think there's a lot of things about this that are really important, Mike. The first is pure biology. We have got to get past this old-fashioned thinking that the only things that matter are blood pressure and lipids. We have known this now for 30 years. It's time to have universal screening for inflammation, and I hope we're going to get there in our new guidelines. The second thing is, this is a study of women. Using standard risk scores, as you know well, women are both underdiagnosed and undertreated. You almost have to be 70 years old as a woman to have enough risk factors to get above whatever threshold people are using to say, aha, maybe 35, 40 years ago, we should have told you, lose some weight, exercise regularly, stop smoking, and at some point, maybe think about a statin. And Mike, the statin piece of this is extraordinary. Once we had these new data about SMURF-less but inflamed, I went back to our Jupiter trial from many years ago. Now remember, Jupiter only enrolled people who had inflammation. But it turns out in that major multinational trial, we had some 8,000 individuals who had no standard risk factors, but all had an elevated CRP, randomized to rosuvastatin or placebo. And Mike, it was a 38% reduction in the risk of major adverse cardiovascular events.
Wow.
So, we are thinking about how do we change guidelines? How do we change the way we think about disease? And I think the only way to get there is going to be universal screening for CRP, just like we screen for LDL cholesterol and for blood pressure.
Now, Paul, was that a positive interaction term, in your Jupiter trial? I mean, did this population significantly modify the treatment effect?
No, in Jupiter, the overall benefit was around 40%, which is exactly the same this group got. But Mike, this group would not even be considered for statin therapy under any current guideline.
Right.
That's what's so interesting here. Now, I'm not saying
Right.
these people should go right on a statin. They should get diet, they should get exercise, they should think about smoking cessation, they should do all the primordial prevention things that a good preventive cardiologist recommend. But I also think if they're going to go on a statin anyway, by the time they're 60, 65, or 70, and men would have started the statin at age 45 or 50, I'm having a hard time understanding why we're not allowing women to at least talk about it with their physicians in those discussions that we have about, hey, what's your risk and how can we prevent these bad events? And the
So
stroke
Paul,
part about this is really important. None of us
yeah,
want to have a stroke.
no, one of the most feared complications. So Paul, this is a great surrogate, right? It's related to long-term outcomes, treating people with this elevation of CRP, but without risk factors, improves outcomes. But to really make it, to round out all the pieces of the surrogacy here, did treatment lower the CRP?
Oh, absolutely. In Jupiter trial, there's no doubt about it. And there's been replications of that over and over that it's not just a statin. If you lose weight, if you exercise, if you stop smoking, your CRP, your inflammation will come down if you eat well, etc. And you take a statin, it will come down. So we already have that kind of information. I think the real question here is replication and external validity. I'm really thrilled to say that since the time we submitted this data, we've worked with 3 other research groups on a global basis. All of them have found the exact same thing. It's extended to men, it's extended to Europeans. We have one Asian cohort doing the same thing. It's a real change in how we think about prevention, Mike. And I think the idea of this clinical syndrome, SMuRF-Less but inflamed, I'll bet you it's going to become a pretty standard part of preventive cardiology.
Paul, what are we doing right now, today, in 2025, to try and test this out further and to randomize people to treatment based upon this?
Well, the randomization of treatment here will be tricky because while the absolute risk here is relatively small, sorry, to flip it around, while the relative risk is large, the absolute risk is relatively low, as it would be in any lower risk population. What's going on in the inflammation biology world, though, is a real revolution. We are moving well beyond colchicine. We're moving well beyond methotrexate and canakinumab, the things that have been tested so far. My group is running 3 major global trials of IL-6, interleukin-6 inhibition. There's another interleukin-6 inhibition trial being done in our trials in the setting of chronic kidney disease, in HFpEF, and acute coronary ischemia. The 4th one's being done in the setting of dialysis. I'll tell you, Mike, there's 6 or 7 novel anti-inflammatory agents being developed by pharma right now. We're in a fantastically interesting time where the inflammation hypothesis of atherosclerosis, it's not just proven, it's really accelerating itself into all forms of how we think about vascular disease. It's a pretty cool time.
Pretty cool stuff, Paul. Congratulations on 30 years sticking to it, looking at this hypothesis, really leading the way. Thanks for joining us today. And thanks to all of you for joining us here live from ESC 2025.